All right, so good morning, everyone. Today we will continue with the hematology, the second part of the hematology lecture or content. And we are going to start with the hematochromatosis. So the question was raised yesterday about the overload, the iron overload. And I thought that might be of a benefit to at least just review the concept of what is called hematochromatosis. Hematochromatosis, I did allude to that or maybe mentioned that with no great details. Briefly, I went over it Tuesday or Thursday, and I said that people or patients with certain type of anemia, especially with like thalassemia, major, alpha or beta, they require or they usually receive blood transfusions frequently. So they receive like weekly basis or sometimes every 2 weeks or monthly blood transfusion, and they more blood transfusion received, then they receive lots of RBCs, then there is a high rate of destruction of the RBCs, and that would result in a lot of iron overload. So the question yesterday was about the patient who had taken or decided to take too much of iron supplements, and the symptoms or the symptomatology, it's not going to be evident until the patient overload, like iron overload, will be exceeds the limit, like it's extremely high, which is the iron. We have a specific testing. I'm going to mention or at least include the test for the iron overload. But the iron overload from the supplement is not going to be evident in terms of symptomatology compared to patient who is receiving the blood transfusions and then result in iron overload. And I did mention that also that the those patients or these type of cases, they will take a drug or medication called chelating agents like Disferal, and which is a medication to bind the excessive iron, and then it will get rid of that iron in the bowel movement. So that's something or drug to be considered in, for those patients who would develop this hematochromatosis. So iron overload, we'll call it from now hematochromatosis. So this is the definition of the hematochromatosis, which is the iron overload in which is going to be deposited and accumulates in certain organs, especially the liver, the pancreas, heart, and adrenal glands, testes, and pituitary glands. These are the organs in which the iron is going to accumulate and deposit in these organs. And that will result in the dysfunction in these organs. So you will.
I'm sorry,
yes.
we can't see your screen.
I'm sorry?
We can't. I can't see. We can't see the PowerPoint.
Okay. Post it one more time. Or share one more time. Now? What about now?
Yes, thank you.
You can see it? All right, you can see it. So that's the definition of the hematochromatosis or iron overload. Yeah,
yes, Professor.
So we have a first degree and second degree hematochromatosis. The second degree is, the belong or you can apply that to the patients with sickle cell anemia, thalassemia, like alpha thalassemia. We said we have two different types of thalassemia, which is a type of anemia. And we talk about that, discussed this thalassemia yesterday, who would be affected by thalassemia. So the patients with hematochromatosis will be presented with, these are the signs and symptoms: abdominal pain, and they will end up with the, with diabetes mellitus, with, hypogonadism, arthropathy, which is the changes in the synovial joints, and pain associated with that as well. And patient will have also the other manifestations. Now, the hallmark of this, you will notice that the patient's skin also become like bronze pigmented, in terms of the discoloration of the skin, due to the deposition of the iron under the skin, and that what gives it that kind of color. In addition to the enlargement of the liver, hepatomegaly, the complications associated with this disease is the patient will end up with liver disease like liver cirrhosis, hypogonadism, hypopituitarism, diabetes. These are like expected complications from the iron overload. So it is a serious complication. That's why the patients um, uh, develop with thalassemia, they end up with one or more of these complications. And one of the surgical treatments or the preventive measures to at least delay the progression of the disease or delay the progression of these complications is that they remove the spleen, because we know that the spleen is aids or assists in the destruction of the RBCs. So the patient will have splenectomy as part of because also the spleen will be enlarged as well, splenomegaly. So they will have the spleen removed. There's a lot of this. I mean, I can spend like 30 or 40 5 minutes to talk about this, but this is would be like more advanced pathophysiology. So let's just keep it to that level and look at the question. And I will ask Dana, can you read it, please? I'm going in like an order to call people's name to read the questions, please.
A 56-year-old man has brittle diabetes, difficult to control with widely fluctuating blood sugars, tan skin, and a family history of cirrhosis. Select the cause A through G that is probably responsible for the patient's presentation.
So it's A, B, C, D, E. It's I removed the difficult ones anyways from the answers. But just this is an example of a scenario. How would you to apply the content or the concept we learned on and answer the question. So the patient now, if you are going to highlight or underline the key points or elements, I mean, or words, you will highlight the brittle diabetes. So patient is diabetic, and then tan skin, and then a history of cirrhosis. So this is the answer would be hematochromatosis. So hematochromatosis, which is genetic disorder of iron or of the iron metabolism. And this is different from the patient who would develop this from the overload, which is from the frequent blood transfusion, for example. So we have, remember that we have first degree, which is autosomal recessive disorder, which is like this case. And we have the secondary hematochromatosis, which is a patient who will develop that from the frequent or chronic blood transfusions. So this is just to answer, the question from yesterday, and make sure that we have a full answer to the question about the iron overload. Any questions about the iron overload? Okay, so continue with the with our content. Just to highlight about the hematochromatosis is that the patients, the liver disease, it kills more people than heart failure in hematochromatosis, because in patients with hematochromatosis, they develop complications like liver disease and heart disease. But the percentage of liver cirrhosis, liver failure, is way higher than the cardiac failure. So the cirrhosis account for about 60% of all cases. Heart failure or cardiac failure is about 15%. So liver cirrhosis is the most common and more prevalent complication status post the hematochromatosis. because of that iron depositions or accumulation in the liver. So next is the leukocytosis and leukopenia. And we went over this, right? We covered this yesterday. I added also one more slide, supposed to be.
We left off on the leukocytosis slide. You said you
would. Yeah, I added also a blood lab results for the CBC, just to show you the how to measure the CBC. Let me just add it right now to the slides, because I want to show you how to review the lab results when you review the CBC, complete blood count, white blood cells, and how to calculate for the ENC, the absolute neutrophil count. And I just want to add that one slide. Okay, so the slide has been added, which includes this table, because I want to show you how to review and read, the white blood cells. I mean the results for the CBC or the CBC complete blood count values and results and reference, ranges and how to read these results. So the first of all, that the white blood cells, the count will be provided in terms of thousands. Like this is the values for the patient, and these are the reference ranges, which is within defined limits or the normal values. So supposed to be from 3.9 up to 11.1, and this is for adult. I believe that should be adult male, I think. But anyways, but this is the white blood cells will be in thousands, and then the differential, which is the neutrophil count. For example, all the differential white blood cells will be in percent. So it'll be percent. So the neutrophil will be 40.1% out of the 5,200 white blood cells. Eosinophil will be 0.6% out of 5,200 thousands of white blood cells. And that's how would you read the results. And then as and you go also to basophils, it's 0.3% out of that total white blood cells of 5,200. So this is because we can calculate the ENC, which is the absolute neutrophil count. It's given anyways. Most of the lab results or the labs, they calculate these absolute values for total neutrophil absolute count, lymphocyte absolute count. It's given also, it's calculated, but you can calculate. I'll show you how to do the calculation if it's not provided, or if there is question that ask you to do the calculation. First of all, we have two different sets of the white blood cell called neutrophils or granulocytes, and then we have agranulocytes. So the granulocytes are the neutrophils. The granulocytes are the neutrophils and eosinophils and the basophils. So you can remember the NEB, the NEB, and you can easily use this acronym to remember the granulocytes. So granulocytes are the NEB, NEB, say neutrophil, eosinophil, basophil. The neutrophils are the largest percentage of accounts for the largest percentage of the white blood cells. And if we go back to the neutrophil count here, you'll find that the neutrophil accounts here for about 40.1%, almost like half of all the white blood cells are neutrophils. So and normally supposed to be between the neutrophil count should be between 38 up to 80%. So that's the normal range or values for the neutrophils. Now, how to calculate for the absolute neutrophil count is that you will multiply the white blood cells, which is the 5,200, times the neutrophil percent, which is the neutrophil count, which is in percent, which is the 40.1%. And that will provide you with the exact ANC. Now, causes of the granulocytosis, and we said cytosis always means an elevated number. So this is an increased neutrophil count, neutrophilia or granulocytosis. It doesn't mean that when you say granulocytosis, you just focus on the neutrophils. It's just because the neutrophils account for the largest percent of all granulocytes. So the causes of granulocytosis, inflammation or tissue necrosis, infection, physiologic or other hematologic conditions. You can add to that also as drug and chemical ingestion, neoplasm like cancer. So we discussed this in the previous chapters. The first few weeks we talk about the shift to the left phenomena, or you can call it leukomoid reaction. The shift to the left phenomena. This is when there is a need for neutrophils, or there is a need for neutrophils to be increased beyond the supply, especially, for example, when there is this severe infection or sepsis or septicemia. Then the bone marrow will start to compensate for that infection and the septicemia or sepsis by producing a lot of or too much of the immature neutrophils. And these are immature neutrophils that are called bands. They are not segs. The segs are segmented neutrophils. They are the mature neutrophils. The bands are the immature neutrophils. So in the when there is a severe infection, the bone marrow will compensate by starting to produce excessive amount of immature neutrophils called bands, and then it will be released in the blood, and that is called a shift to the left phenomena. We can also indicate this from as we review the lab values, especially the CBC, and you will find that there is an elevated number or percentage of the bands, which is the immature white blood cells or immature neutrophils. Neutropenia, which is the reduction in the circulating neutrophils. And clinically, well, neutropenia will exist when the neutrophil count is less than 2,000. But neutropenia is a condition in which the absolute neutrophil count, not the neutrophil count, the absolute is less than 1,000. Severe neutropenia is associated with when the ANC is less than 500. But clinically will exist when neutrophil count is less than 2,000. The causes will, you can add to the prolonged severe infection or decreased production of the neutrophils, or reduced survival, which is lifespan. And you can add to that the abnormal neutrophil distribution. The hematologic causes or etiologies, the aplastic anemia, megaloblastic anemia. And megaloblastic anemia, you can include vitamin B12 deficiency as one type of the megaloblastic anemia, or pernicious anemia as in megaloblastic anemia. Leukemia, and we'll talk about the different types of leukemias. We have 4 different types of leukemias, and it can be also drug or toxin-induced neutropenia. In addition to that, you add to the list also the bone marrow suppression. Bone marrow suppression. Sometimes it's induced. When do you think this bone marrow suppression will be induced bone marrow suppression? You suppress the bone marrow, you suppress the immune system. When do you think this will be a case in which that we will induce it? That will be for patients who status post graft transplantation or organ transplantation. Then to prevent the rejection of the organ transplanted rejection, patient will take immunosuppressive agents. So the immunosuppressants will be taken. Sometimes patients will take 2 or more of these immunosuppressants to suppress the immune system and prevent rejection. And that will eventually also result in a bone marrow suppression, so the patient will have neutropenia. So those patients should be, careful with, with going into the crowds. And there are certain, things and guidelines for them and instructions to prevent the infections, because they will be prone to infections because they have a suppressed immune system. The immune system is it's compromised or suppressed. Also, you can add to this is the starvation and anorexia nervosa. It is also associated with the high risk for infection, and patients' death would result from sepsis or septicemia, in which that sepsis means that the blood become infected. The bacteria will travel to the blood and the blood become infected. That is sepsis or septicemia. The agranulocytoses the causes will include the immune mechanisms or the immune system mechanisms, the chemotherapy, patients who receive chemo, or being exposed to ionizing radiation. Eosinophils will be involved in 2 conditions or 2 cases. In which do you think that eosinophil will be present in large amounts, in abundant amounts? Will be in 2 different scenarios. You will find eosinophil count will be elevated. 2 scenarios or 2 conditions or 2 diseases. Eosinophil.
Wouldn't it be in like infection?
It is more anaphylactic, which is allergic disorders.
So
Allergy.
inflammation.
Yeah, the allergy. So the allergy, because of remember this hypersensitivity reaction, which triggers the release of eosinophil chemotactic factor for an anaphylaxis from mast cells, which is evident and will be increased in cases like allergic reactions or disorders. So the allergy, remember that allergy when the mast cell becomes sensitized, and then the eosinophil will be elevated. In addition to that, also you can add the infections caused by parasite infections. Parasite infections and allergic disorders, these 2 conditions, you'll find the eosinophil will be elevated because they are involved in the disease process in both allergy and parasite infections. Eosinopenia, which is the decreased level of eosinophils, and that will be present in patients with shock, trauma, burns, mental distress. Mental distress will result in also decreased eosinophil count. The infectious mononucleoses, the commonly caused by the EBV, which is Epstein-Barr virus. About 85% of these of IM, of the infectious mononucleosis, will be caused by the EBV virus. The other viral agents, which will resemble look like the IM, the infectious mononucleosis, would be the CMV, the cytomegalovirus, and that's the virus which cause also infections in patients with HIV/AIDS, patients with hepatitis, liver infection, influenza, HIV. So symptoms, patients with infectious mononucleosis will have fever, sore throat. The lymph nodes, especially the cervical lymph nodes, will be swollen. The lymphocyte count will be increased. Now, the treatment, they will usually they treat the symptoms, so symptomatic treatment of the mononucleosis. Leukemias. The leukemia will, which is the malignant disorder of the blood and blood-forming organs, and the result. So the leukemia would, results in an accumulation of dysfunctional cells because of the loss of the regulation in cell division. So it is a malignant disorder, so which includes or which will in which that there is a dysfunctional cell because of the loss of control in the cell division. So if untreated, it's fatal if untreated. The pathophysiology and etiology of the leukemia, different types of leukemias. These are some of the risk factors. You can call it risk factors or etiological factors that can lead to leukemia. There is some genetic predisposition, familial factor, chemical agents, chemotherapeutic agents like chemotherapy in terms of patients with cancer who receive chemotherapy, viruses, radiation, immune system or immune reactions or immunologic deficiencies. The classification of the leukemia, because we are going to briefly go over 4 types of leukemia, they are classified according to these 2 criteria. So you will say, for example, acute versus chronic, which this is the degree of differentiation that took place before the cell became malignant. Acute versus chronic, which is the degree of differentiation that took place before the cell became malignant. And then the other differentiation, which is the other classification criteria, which is based on the predominant cell of origin. So the predominant cell of origin, either it's the myeloid or lymphoid. For example, you say acute. So these are examples of the 4 different types of leukemias. So you'll say, like, for example, acute lymphoid or acute myelogenous, which is from the myeloid, which is the predominant cell of the origin of the disease, of that specific disease. So we'll briefly just go over each type of the 4 different types of leukemias. The acute lymphocytic leukemia, that's would affect the children the most. So the highest prevalence would be in children, and only about 15% it will be present in adults or affect adults. But most would be affected by that as the children of the acute lymphocytic leukemia. The most prevalent signs and symptoms would be fever and bleeding of all different types. Internal bleeding, external bleeding, petechiae, bruises, ecchymoses, in addition to the weakness and fatigue. And you can add to this also central nervous system manifestations. The chronic lymphocytic leukemia, This is a type of leukemia in which that you'll find the B cell involvement. And if you take a look at the chart, you'll find, or the flow chart, you'll find here is the chronic lymphocytic leukemia, and there is a B cell involvement. And that could result in what is called the multiple myeloma, which is another adult type of leukemia that affects adults, multiple myeloma. But the chronic lymphocytic leukemia, it's there is a B cell involvement. There will be in lymph node enlargement. Lymph node enlargement. And that will be systemic, like throughout the body, for the, which is called lymphadenopathy, lymph node enlargement, or lymphadenopathy, systemic, the entire body. Then that will result in increased incidence of infections due to that. Now, the complications from early stage of chronic lymphocytic leukemia is it's not that quite often, or so it is rare. And the complications may develop as the disease advances, but it's not as quite often as the acute lymphocytic leukemia in terms of the complications. Like patients would develop pain, which is generalized pain, paralysis, and paralysis will be from the enlarged lymph nodes, which will cause pressure on adjacent organs and on the joints. And take a look at the patients with lymphadenopathy. Like this. So this will be few illustrations for patients with lymphadenopathy, which is the enlarged lymph nodes. The next type of leukemia would be the acute myelogenous leukemia, which accounts for about 1/4 of all types of leukemias and mostly affect adults. So 85% in adults. The onset is dramatic and it's abrupt, sudden. It's not like slow progression or insidious. It is abrupt and very fast and dramatic onset. Patient will develop abnormal bleeding. They will develop serious infections. And the patient will have a hyperplasia of the bone marrow and the spleen. The chronic myelogenous leukemia, it's associated with what is called the Philadelphia chromosome. That is the genetic marker for this disease. And it has been, proved, and there's a lot of empirical evidence that the disease is associated with this specific chromosome, chronic myelogenous leukemia. So this chromosome is responsible for the development of this disease. The signs and symptoms of different types of leukemias, you can add to the list in this slide also the enlargement of the liver, spleen, and lymph nodes, like hepatosplenomegaly and lymphadenopathy, in addition to all these symptoms. So lymphadenopathy, which is the enlargement of the lymph nodes. And the enlargement of lymph nodes is, it could result also in the lymphadenopathy, result in the proliferation of lymphocytes In addition, we said also the enlargement of the lymph nodes, and the lymph nodes, when it's lymphadenopathy, so it is large enough to be palpable. You can, as you palpate, the lymph nodes, you can feel them, and also it's tender. The enlargement, that's due to the increased size and number of lymphocytes and monocytes, or due to the invasion by the malignant cells. It can also be affected by adjacent malignant tumor that will invade the lymph nodes, and that then we say it is metastasis, right? So we said that TNM classification, the N, which indicates the involvement or the effect of the cancer on the lymph nodes, or if there is an involvement of the lymph nodes in the disease process. So that could also result from the invasion of malignant cells. So again, it could be local lymphadenopathy, which will indicate the drainage of an inflammatory or infectious lesion located near the enlarged node. So drainage of the inflammatory or infectious lesion located near or next to the enlarged node, that's local lymphadenopathy. And then we have general lymphadenopathy, which is associated with infection. And that will occur in other types of leukemias like NHL, which is non-Hodgkin lymphoma, or CLL, chronic lymphocytic leukemia. So the lymphadenopathy would result from 4 different conditions, either from cancer, which is neoplastic disease, or from the immune reactions or conditions, immunologic or inflammatory conditions. Endocrine disorders also can lead to lymphadenopathy, in addition to the lipid storage diseases. So neoplastic disease, immunologic or inflammatory conditions, endocrine disorders, and lipid storage diseases. The malignant lymphomas, it includes 2 major categories: Hodgkin's lymphoma or non-Hodgkin's lymphoma. The difference between, so we'll just go briefly over the difference between Hodgkin's versus non-Hodgkin's lymphoma. Hodgkin's lymphoma, which accounts to, for about 15% of all lymphomas, and it was named after the first one was affected by the disease was Thomas Hodgkin, who described the disease back in 1932. The disease, this is the hallmark about diagnosing patients with non-Hodgkin's lymphoma, which is the presence of what is called special cells or specific cells called Reed-Sternberg cells. They are multi-nucleated cells. The presence of these cells in the lymph nodes, it indicates the presence of the disease, or we can diagnose the disease, but not confirming the diagnosis, but at least it can assist in diagnosing the Hodgkin's lymphoma, the presence of these cells. They are necessary for diagnosis, but they are not specific to Hodgkin's lymphoma. These are the 2 age groups that will be affected by the most likely to be affected by Hodgkin's lymphoma. The cause is still unknown or remains unknown, but there are some factors, we can call them risk factors or key factors, that play a role in the development of Hodgkin's lymphoma, like the infection with or being infected with EBV, which is Epstein-Barr virus. Another risk factor is genetic predisposition or exposure to occupational toxins. It can be asbestos, can be carbon monoxide, it can be so exposure to occupational toxins. So Hodgkin's lymphoma, the disease began above the diaphragm. So the lymphadenopathy or the enlarged lymph nodes involved in Hodgkin's lymphoma, it's above the diaphragm. So all lymph nodes above the diaphragm, when it's enlarged, that could indicate the Hodgkin's and it's not the non-Hodgkin's lymphoma. So the disease remained confined to lymph nodes for a variable amount of time above the diaphragm. And these are some of the symptoms and findings or physical findings for patients with Hodgkin's lymphoma, especially the fever and the weight loss. Weight loss and the night sweats. The weight loss and night sweats and the fever, they are very significant. So as we diagnose or as we assess the patients and diagnose them for Hodgkin's lymphoma, but it will be the physical findings and symptoms in addition to the presence of the Reed-Sternberg cells in the lymph nodes. But back to the lab values or findings, the patients with Hodgkin's lymphoma, they will have also a significant decrease in platelet count. Increase in platelet count because of the enlargement of lymph nodes, thrombocytoses, leukocytosis, elevation of white blood cells, eosinophilia also, and elevated ESR. The ESR, which is erythrocyte sedimentation rate, ESR. The ESR is, you will anticipate the elevation of the ESR, the erythrocyte sedimentation rate, in patients with any inflammation. It's not specific to any disease, the ESR, but it's the ESR, erythrocyte sedimentation rate. Again, ESR, it's not specific to any specific disease, but it will be elevated in any inflammation. During any inflammatory process, the ESR will be elevated. And that will be also present here with the thrombocytoses, leukocytosis, eosinophilia. So Hodgkin's lymphoma, and you can look at the cervical lymph nodes, how it's enlarged and swollen right here. So non-Hodgkin's lymphoma, which is the genetic term for a diverse group of lymphomas. The involvement of so there are different cells that are involved in this disease, which is the B cells, the T cells, and the NK cells, natural killer cells. The disease is classified according to the different cell characteristics, classified according to the lymph node characteristics. And we have different types of the non-Hodgkin's lymphoma. If the B cells are involved or are involved in this disease, or if the T cells or the NK cells, the natural killer cells, the majority of the non-Hodgkin's lymphoma cases, they have the B cells involved, about 90% B cells, and about 10% of T cells or NK cells. The non-Hodgkin's lymphoma, we have different types of non-Hodgkin's lymphoma. One of them is called Burkitt lymphoma. Burkitt's lymphoma. That's one of the three, major types and the most common one. the Burkitt lymphoma. That's the most common type of non-Hodgkin's lymphoma in children. So it accounts for about 30% of childhood lymphomas worldwide. In Burkitt's lymphoma, the B cell, it will undergo chromosomal translocations, in which that will result in the overexpression of the specific gene and the loss of control of cell growth, which is, in other words, cell division will be accelerated and will result in the signs and symptoms of the Burkitt lymphoma. Especially, it affects the jaw and the facial bones. So the Burkitt lymphoma will result in a very fast-growing tumor of the jaw and the facial bones. So that's concludes the different types of lymphomas, and now we have few case studies and questions to apply what we have learned about these lymphomas. So let's start with the first case study.
Can I ask a quick question, Professor?
Go ahead.
So you said there are 3 major types, but we're just covering one.
Just one of them, yeah, because that's the most, I would say, prevalent and common and most important one. Yeah.
Thank you.
Just Burkitt's lymphoma, and I think also we will cover this in PEDS course as well. Okay, so can I ask Maria to read the case study, please?
Max is a 60-year-old male living in Iowa. For 27 years, he has been working in the agricultural industry, particularly in the management of corn production. Recently, he began to feel weak during work and tired easily. During the night, he woke up sweating, and he often felt unusually warm during the day. Max was also surprised that despite eating regularly, his weight was declining, and his work pants were now too large for him. Upon physical examination, his physician noted that his inguinal lymph nodes were swollen, although Max said they weren't so. Subsequent laboratory tests confirmed follicular non-Hodgkin lymphoma. Chemotherapy in conjunction with rituximab was immediately initiated. Describe the key cellular difference between HNL and HL.
Okay, thank you. The rituximab, I sometimes, in path we have to cover some pharmacology. We cannot evade this. So this is like, something that you cannot evade it. So we have to include some pharmacology. Rituximab is the Rituxan. It's the brand, this is the generic name, and the brand name is always in parentheses, will be Rituxan. Oh, sorry. Yeah, it's Rituxan. All right, so this is the brand name for the rituximab, which is the anti-neoplastic drug. When you see anti-neoplastic, which is anti-cancer drug or chemotherapy, right? Chemotherapy or anti-neoplastic. Now, so the first question, I'm just going to go briefly over the questions because that's kind of a review. But just take a look at the syntax or the scenario, the scenario, and highlight the things that pertains to the non-Hodgkin's lymphoma. like symptoms or manifestations that pertains to that non-Hodgkin's lymphoma. I would say feel weak during work and tired easily. So that's generalized weakness and fatigue. Night sweats. Felt usually warm during the day, which is low-grade fever or fever. And then weight was declining. So the weight loss, with evidence of the weight loss, that the pants were not too large for him. And you can add to this also the inguinal lymph nodes, swollen, enlarged, lymphadenopathy, especially it's follicular, so it's only in one, just in the groin. So given it's below the diaphragm, we always think of the non-Hodgkin's lymphoma, because the Hodgkin lymphoma will include lymph nodes above the diaphragm level. And they are not sore. So patient is not complaining of any pain. And that's also evident that patients with non-Hodgkin's lymphoma, they will have lymphadenopathy, enlarged lymph nodes, but not associated with any pain. So the first question is to describe the difference between non-Hodgkin's and Hodgkin's lymphoma, and we did, just covered that in the previous slides, and just the key feature of the Hodgkin's lymphoma or Hodgkin's disease is the presence of the Reed-Sternberg cells, and this cell is not going to be found in the non-Hodgkin's disease. So this Reed-Sternberg cell will not be present in the non-Hodgkin's lymphoma. It's only present in the Hodgkin's lymphoma. Second question, the non-Hodgkin's lymphoma disease is a multi-centric in nature and often present with painless generalized lymph adenopathy. So patients do not complain of any pain due to that lymph node enlargement. Painless generalized lymph adenopathy. With one lymph node or with several nodes involved. But the Hodgkin's lymphoma disease, it's a single enlarged node, only one node, or and most likely they complain of pain due to that lymphadenopathy. The third question, which asks about the rituximab, which is the Rituxan, which is a drug that is chemotherapy or therapeutic agent, chemotherapy agent. And there is a mechanism of action. You're not, you have to know this because this is a pharmacology stuff. But at least it's a drug in which that the mechanism of action will destroy the malignant cells. And it's very effective chemotherapeutic agent in patients with non-Hodgkin's lymphoma. Next case, we can ask Amy, please. You can read it.
PD is a 7-year-old girl who was brought to her physician by her mother with complaints of general fatigue, anorexia, and unexplained bruises and rash for the past 2 weeks. Current status, PD's vital signs are temperature 98.6, heart rate 92, blood pressure 90/60s, respirations 18, height and weight in the 55th percentile. Her skin is warm, pale, and dry, with bruising on the extremities and trunk. Examination of the skin reveals small petrol lesions on the arms and legs. Petechial lesions on the arms and legs. There is no hepatosplenomegaly. There are 3 palpable non-tender lymph nodes in the submaxillary chain. you want me to read the lab data?
No, that's fine. So we have the lab values, which is the low hemoglobin, hematocrit also is low. In addition to the RBCs, what blood cell count is extremely high, 45,000, and it shouldn't exceed the 10.5 or 11,000. The platelet count is extremely low, 50%, 50,000, which is supposed to be at least minimum of 150,000. So the bone marrow aspiration, which is a test, lumbar puncture was done, and other studies also performed and revealed acute myelocytic leukemia, which is consistent with what we said previously, that it affects the ALL, which is acute lymphocytic leukemia, or lymphoplastic, the same. It affects children the most. So what cell type is abnormal in cell lymphocytic or lymphoplastic leukemia?
It will be related to the lymphocytes?
I'm sorry?
It will be related to the lymphocytes?
Right. So the leukemia is abnormal. We know that it's abnormal production of one of the different blood forming cells, which is a white blood cell. So in this case, it is the abnormal, it is the lymphocyte, yes. So it is the overproduction of abnormal lymphocytes. So in this child, or this scenario, the child has acute lymphocytic leukemia or acute lymphoplastic, the same. When you say lymphocytic or lymphoplastic, ALL, acute lymphoplastic or acute lymphocytic leukemia, which is the most common type in children. And we said it accounts for about 80 up to 90% of leukemias in all age groups. Second question, what the clinical manifestations or signs would suggest the leukemia, and what is the physiologic rationale for that?
Wouldn't it be her white blood cell count being so high?
Right, so the extremely high white blood cells, that's an indication, which is the leukocytoses. And other manifestations of leukemia?
Had bruising on the
bruising, yes,
extremities?
the bruising, which is the petechiae, purpura, bleeding, the bruises, all of that is due to lack of or low, which blood count? Which one is low? I mean, the low platelets, yes. Platelets is 50,000 and supposed to be at least 150,000. And then the decreased number of RBCs that kind of give, the skin the pallor color, and decreased oxygen carrying capacity, which is hypoxia, would result in patients to experience the fatigue and the generalized weakness. And then also, and you can add to this also the epistaxis, which is a nosebleeding, excessive bruises, and hematuria. They are often occur in children due to that decline or decrease platelet count. Yeah, so these are the physiologic changes which has resulted in the manifestations. Now, as we review the lab values, and we will find that the white blood cell count is elevated. There is from the rapid proliferation of the abnormal lymphocytes, which accounts for the largest number of the white blood cells. The 10% blasts indicate the bone marrow suppression. Bone marrow is producing and releasing abnormal white blood cells to function. I mean, these blood vessels that are not able to function to prevent infection. So the large number of white blood cells in the bone marrow, we have too many of these white blood cells, but they are ineffective, which is, in other words, that we say it's, it's a shift to the left phenomena, because the patient, the bone marrow is compensating by producing immature cells. These cells are immature. The platelet count is 50%, which we said it's supposed to be between 150 up to 450. and which has resulted in all of these symptoms, most of them linked to the hemorrhage, bleeding, epistaxis, and petechiae, and ecchymosis, and other and hematuria. Multiple myeloma, it's not required. I'm not asking, that we go over it, so it's not that important. Thrombocytopenia. Thrombocytopenia, which is the decrease in platelet count, and we know the ranges or the reference values 150 up to 450,000. And I listed here all the causes or expected etiologies of the decreased platelet production. And another set of etiologies would be due to the thrombocytopenia would result from not from the production, that there is a decrease or decline in production, but more of consumption. That is, we are consuming too much of platelet cells. And an example of this would be patients with DIC, disseminated intravascular coagulation. These are the two, the first one and the last one. These are the two conditions that I will highlight more than the other three. I mean, we have 4 different types of etiologies or diseases consistent with that increased platelet consumption. We'll just highlight the first one and the last one, which is the HIT and the DIC. These are the most common, and they are the more important than the others. So the first one is the HIT and the DIC. So the HIT, which is the heparin-induced thrombocytopenia, in which that I know that it affects very small percentage or portion of the population, in which the people, the 4%, they have tendency to develop this. So once you start them on heparin infusion, their platelet count will drastically drop and decline, and that is called HIT or HIT, which is heparin-induced thrombocytopenia. It's an immune reaction or immune mediated, and the drug or the adverse drug reaction. So once they start on heparin, that drug is going to result in what is called the IgG antibodies. These IgG antibodies, immunoglobulin type G, they will start attacking the heparin platelet factor 4 complex. It will be like antigen antibody complex, and that will attack the platelet cells. So the IgG antibody with the antigen produce the antigen antibody complex, and it will attack the heparin, the platelet count or the platelet cells, and then it will result in the destruction of the platelets. So that's why the patient with the HIT will end up with thrombocytopenia. The vitamin K deficiency and liver disease. I just included this just to illustrate the blood clotting and the different pathways of the blood clot formation. The thrombin, how the thrombin is a significant component of the blood clotting, and then it will convert the fibrinogen into fibrin, and that will be the significant component of the blood clot eventually, which is called the coagulation cascade. And it's very complicated when it comes to external and intrinsic and extrinsic pathway, but these are the important pieces of the whole puzzle, which is the coagulation cascade. Is just to remember the thrombin and the fibrin. The clotting factors, most of these clotting factors that which aids in the formation of this blood clot, comes from the liver, which explains why patients with liver cirrhosis or liver disease, they have problem with producing sufficient amount of clotting factors. That's why they have a tendency for bleeding or hemorrhage. So patients with liver cirrhosis or liver disease, they have a tendency for hemorrhage and bleeding because the liver failure or liver disease doesn't produce sufficient amount of clotting factors, which eventually won't be able to continue the process of coagulation and result in blood clotting, so that they will tend to develop the bleeding or hemorrhage. The vitamin K deficiency, it explains the in pharmacology, in the pharm course next fall, you will go over the anticoagulant medications or what is called blood thinners, and one of them is called warfarin sodium or Coumadin, and it works on this, on vitamin K deficiency. Now, the Coumadin and warfarin sodium, it's can be antagonized with vitamin K. So patients who took too much of the or overdose with Coumadin or warfarin sodium, overdose with that warfarin sodium, and they tend to to have bleeding or hemorrhage, the vitamin K will be the antidote for that. However, for patients who take the heparin, the antidote is different because the mechanism of how heparin works is different than the Coumadin, warfarin sodium. Heparin, the antidote for the heparin, so patients who had received lots of heparin and they eventually develop the hemorrhage from heparin overdose or from the prolonged bleeding time, then the antidote for that will be protamine sulfate. So protamine sulfate is antidote for the heparin overdose, and vitamin K is the antidote for the Coumadin warfarin sodium overdose. So this just go over the blood clot dissolution or blood clot fibrinolysis, which in other words is the disintegration of the blood clot. Our body, since we have intrinsic and extrinsic pathway to develop the blood clot, also there is a mechanism to lyse or to disintegrate and to dissolve the blood clot. So it's called lysis of blood clot, which is done by the fibrinolytic system from fibrin. So from fibrinolytic system, like plasminogen and plasmin, fibrin degradation products, they are going to involve and result in the disintegration and lysis of the blood clot. It will be dissolved. It may take time, so that's the natural homeostasis. Even if there is small tiny blood clot, healthy hematology system will result in the disintegration and dissolution and the breakdown of that blood clot. However, if the patient has developed, let's say, like DVT or deep vein thrombosis or acute MI, we have to intervene with adding a drug medication called TPA, tissue plasminogen activator, to aid in the dissolving or in the degradation of that blood clot. So the DIC, which is disseminated intravascular coagulation, that's the other form of in which that patient will develop the thrombocytopenia and platelet count will drop. However, in the DIC, it says disseminated intravascular coagulation. So it's kind of covered it's disseminated, so it covers the entire systemic, like it covers the all hematologic system or blood vessels. The blood clots, so the patient with DIC, they will start with forming thousands of hundreds or maybe thousands of small tiny blood microemboli, microthrombus, very small tiny thrombus or blood clots throughout the systemic, vascular system. In other words, that when the blood is going to develop these thousands of small tiny blood clots, it will use too many of the platelets. So the platelet count will drop. So at the beginning, the patient, the DIC, it takes two phases. First, blood clotting, and then eventually from the use of the platelet count, then the patient eventually will end up with bleeding. So the first phase would be the blood clotting, and then the next phase would be the hemorrhage and bleeding. That's why you'll be surprised to see that patients with DIC will be treated with heparin drip, anti-coagulant medication, blood thinners. That's before the patient developed the bleeding or the hemorrhage, because the first phase, the blood clotting, micro thrombus, and then from the overuse or the overuse of the platelet count, then that patient will eventually develop the bleeding or the hemorrhage. So that severe bleeding will be the last phase of the disease process. So the DIC, the D-dimer, there's a link on a video, I believe, YouTube or video on the Blackboard, describes the difference between the FDP and the D-dimer. The FDP, which is the fibrin degradation product, and the D-dimer, it results from the D-dimer will increase in patients with a DIC. Both of them will be increased. Both of them, they are the remnant, or they are the byproduct of the destruction and the lysis of the blood clot. So their presence indicates that there was blood clot, that their patient had experienced a blood clotting, because once the blood clot has disintegrated or been dissolved, then the D-dimer and the FDP as byproduct of that blood clot destruction, these two components will be present in the blood as an indication of the previous presence of blood clots. So we have to, we treat the disease by removing the stimulus or the precipitating factor or the causative agent. So we can indicate the presence of the DIC in terms of clinical manifestations, that presence of like bleeding from the vascular sites. For example, patient has a venipuncture, or a patient has a arterial line, or a patient has any catheter, IV catheter, and if there is bleeding from the IV catheter, that is an indication for DIC. Or the petechiae, hematomas, the systemic cyanosis, symmetric cyanosis of the fingers and toes, like both sides have cyanoses. That's also an indication of DIC. Questions? What do we have?
Professor, just
Yes.
to make sure, so the FDP and the D-dimer, basically both they will work to check the coagulation time. So I know usually people who go for a surgery, usually they
Yes.
order a D-dimer because it's gonna check the coagulation time. It will be used the FDP as well, or is different?
No, D-dimer is more indicative of more than the FDP. Yeah, the D-dimer is more diagnostic usually, but it doesn't mean that there is no reason why I would for not requesting for both. But D-dimer is more diagnostic.
Oh,
The
thank
difference
you.
between these two will be more. I would say that you will find more explanation about the difference between D-dimer and the FDP on that video I posted on Blackboard.
Okay.
But D-dimer is more diagnostic. So questions, Jenny, can you read the question, please?
You said me, Professor?
Janet, anyone? Yeah, go ahead. Thank you.
Okay. I'm sorry, thrombocytopenia is commonly seen in which condition?
Would be that B?
D, right? Which is disseminated intravascular coagulation, DIC, right? So the thrombocytopenia is defined as platelet count less than 150,000. Most common forms of thrombocytopenia, we said it's would result from the increased platelet consumption, which included the 4 different types, and we highlighted 2 main ones: the heparin-induced thrombocytopenia, which is the HIT, and the DIC. And we said there are 4 types of of causes, but we kind of highlighted the 2 scenarios or the 2 disorders, which is the HIT and the DIC. Yeah, multiple myeloma is a neoplasm. Also, it's a cancer as well of the B cells. When there is immature plasma cells, immature B lymphocytes, and it doesn't affect the platelet counts. The hemolytic anemia that results from the premature destruction of the red blood cells, not the platelets. Non-Hodgkin's lymphoma, they are a B cell neoplasm, and the hallmark of the disease, we said it's a lymphadenopathy, and it doesn't affect the platelet production. Well, we finished on time. It's good. Even we have 15 minutes left. All right, so any questions? We have 15 minutes. If you have any questions, if not, then I'll let you go.